Thank you. Okay, so thank you for everybody who has come along in person, but also thank you very much to those who have joined us online as well today. There's quite a few of you there, so we very much appreciate your patience while we sorted out the technical issues that we had. For those of you who teach, I'm sure this is not an unusual situation because it happens sometimes. So just to introduce both the session and myself. So today's session is about understanding menopause. And I look at the demographic that have joined us today, certainly in the room, and I think we want to either be prepared or we might want to be sharing our experiences of what's actually happening during that period of time, which might be quite lengthy. So I think this is a really, really valuable and important session, and it's very important that we listen, talk about experiences, but also talk about potential practical solutions to the different things that each of us faces in our own journey in the menopause. Introduction to me, I'm Lois Farquharson. I don't think I've met many of you before. I'm the Executive Dean of the Business School here at Bournemouth University, but I am also the Chair of the BU UHD, University Hospitals Dorset Partnership, and I chaired the steering group. So events like these are of the utmost importance and really add value. The partnership itself has been in place since 2020, and I've been involved with it from that point. And one of the things that I would say that really impresses me about our partnership with UHD is actually the collaboration, the transparency and the openness that we have as a group to actually look at key issues that ultimately may address things like health inequalities in the region. So there's a huge amount of will in the partnership to address key issues and actually make real impact. One of the things that also has really struck me, and the reason why I'm involved with the partnership, is really about interdisciplinarity. I'm not clinical by any manner of means, but what I am is a business specialist, so my interest is in change and how that works for people, or rather doesn't work. Things like organisational behaviour, psychology, and things like that. So you can see why there would be a really nice interdisciplinary crossover between areas that I'm interested in as a business specialist with health areas. One of the things the partnership is looking into right now, which is a huge issue for the NHS right across the UK, is workforce, the long-term workforce plan, which came out last year. So actually looking at what we can practically do to build the capacity and the capability of a workforce that is under tremendous pressure and stress. So that's one of my key areas, and I enjoy working on it, but it also fills me with lots of concern around the support that's needed going forward for people who basically spend what is their life and their vocation to work in the NHS, and we need that. So I am going to stop there, but if anyone wants to be involved with the partnership or ask me more questions about how they can be involved with the partnership that we have with University Hospitals Dorset, I'm always happy to talk about it. And that is across staff, students as well. We do placements, we have new degrees, biomedical sciences, we have apprenticeships. There's all sorts of things included in the partnership as well. But ultimately what we're there for is to actually make things better for patients and communities and address some of the big issues that we have in the region. So, Nat, I need to do a little bit of housekeeping before we move on.
Thank you so much. I'll take over here. Yeah. Hello, my name is Nathaniel. I actually sit with Lois on the steering group for the BU UHD partnership, and I think I've got the best job on it because I'm the communications guy, and so it's my job to look at all the brilliant things that go on across both organisations and take a camera along and film it. So I've been able to see firsthand all the brilliant things that they do. That being said, it does leave me to talk about the housekeeping for a second, and if you are online, you'll have to bear with us. I assume you know where the toilet is in your own location, so I shan't labour that point. But here, just over the way there's some single occupancy bathrooms. And we're not expecting a fire drill, so if you do hear an alarm, then head out here, down the stairs, and on your way out. That being said, it is my honour to introduce our speakers. You have two of the finest coming to talk to you on the subject of understanding menopause today, and I'm so grateful that you have joined us. Up first, we have Rosie Harper. Rosie is a clinical specialist pelvic health physiotherapist at University Hospitals Dorset and has a second hat as well here at Bournemouth University, where she's a clinical academic PhD student, and so sees that partnership from both sides as well. Now, Rosie's already warm because she's been on BBC Radio Solent this morning talking about this very subject already, so you can prepare all your hard questions because she's already warm and ready to go, okay? So why don't we give her a round of applause, even at home. Give her a clap, come on. We'll welcome her in.
Thank you, Nat. So I hope everyone can hear me at home. Please let me know if you have any difficulties. I'm always happy to talk about this important topic, and I think the interest in the room and the number of people that we've had interest online just shows the importance of this topic, and I'm really, really pleased to see that both Bournemouth University and UHD have got together and organised this really important event. So thank you all for coming. I'll check my slides working first. Let's have a little look on here. Wonderful. Okay, so I'll use the clicker. So as Nat said, I'm lucky enough to work at both Bournemouth and Poole Hospital. I work as a clinical specialist pelvic health physio, and my PhD research is specifically looking at women's adherence to pelvic floor muscle training. So in terms of the objectives of this talk, hopefully we're going to help you and all of us know understand how menopause can affect the vagina, vulva and bladder. Look at the common signs and symptoms that commonly arise around that perimenopause and menopausal period. Think about the risk factors of developing symptoms of pelvic floor muscle dysfunction, and thinking about how we can prepare ourselves going forward. And then some lifestyle advice, tips, information, and how you can look after your pelvic health going forward. So this slide probably looks all too familiar. And the importance of this slide shows how in earlier reproductive years we are quite cyclical beings. We're used to a big change in hormones through the reproductive years, and then as we approach perimenopause, that estrogen seems to kind of go all over the place. The levels vary, goes up and down, it becomes a little bit more unpredictable, and there are some common signs and symptoms that go with that. Looking forward to postmenopause, that estrogen then slowly drops off, and it's important that we recognise that when we're thinking about menopause and perimenopause, these are predictable changes in our lives. We can kind of predict the reproductive years as well as menopause, and so thinking about when that might start to come around, things to look out for, and things we can sort of think about and talk about are really reflective of the changes in estrogen that we can experience. So, the role of estrogen, what does it do and why is it important? Estrogen has three key roles in relation to pelvic health. It maintains vaginal tissue, it maintains bladder function, and it maintains muscle mass and strength. So thinking about vaginal tissue in particular first, I tend to liken the vulva and vagina to be a bit like the inside of our cheeks. They're meant to be stretchy and elastic. If you look on the inside, they've got a really good blood supply. They look a bit pinkish or reddish. And they're well lubricated as well. So these are the kind of characteristics you want to maintain through the menopause. And what estrogen does is it helps maintain the epithelial cells that line the inside of the vagina, that maintains that elasticity in the tissues. Because in terms of function, the tissue is designed to be elastic and mobile to allow for comfort as they kind of move over each other. In terms of bladder function, a lot of us when we pop to the toilet think it's quite a passive activity. We pop when we go to wee and then we leave, but actually there's quite a lot of processes involved in going to wee. There's a muscle that sits around the bladder that tells you when you want to go, and it actively squeezes and wrings out the bladder to allow you to void properly. And estrogen has a really important role in allowing the bladder to fill up properly and allow you to hold urine. When we think about muscle mass and strength, that's particularly important when we think about the pelvic floor. So the pelvic floor is the muscle at the very bottom of us that's no bigger than our hands, sort of on top of each other, and it sits around the bladder, vagina and back passage, so it has a really, really important role in how those organs function. When we're thinking about how that muscle contracts and relaxes functionally, it's important that it can contract fully, maintain a contraction, and it's got enough muscles in there to be able to do its job. So thinking back to that previous slide, if estrogen kind of varies and then can drop in later life, it does have a significant role on how these structures function down below. The kind of symptoms that we can get in relation to perimenopause and menopause can have a significant effect on people's quality of life. I see a lot of ladies in clinical practice who come in who struggle to exercise properly, have difficulty with intimacy with their partners, and some even struggle to leave the house. So it's really, really important that we talk about these sorts of symptoms to allow people to access health and help and health when they really need it. So, common bladder symptoms that can occur around the perimenopause and menopause. Urinary frequency, going to the loo more often, and going to the loo more often at night. Urinary urgency, that sensation of, okay, I need to go to the loo, but I need to go now. You can't put it off. You feel everything feels quite urgent and you can't delay. Some women experience an increased frequency of urinary tract infections, and I get a lot of ladies coming in and saying, I've just got that kind of irritation, discomfort, I feel like a UTI is coming on, it feels quite sensitive, it feels quite irritated, and also sometimes thrush can occur around that period of life as well. Other symptoms that can affect the bladder include urinary leakage, and that can be related to stress urinary incontinence that occurs if someone coughs, sneezes, laughs, or tries to run. You get a little bit of leakage of urine, and also urinary urge incontinence. You don't quite make it to the toilet in time when you feel that urge to go. Common vulvar and vaginal symptoms. Now, I've chosen this photo quite intentionally, and I just draw your attention to the colour of the flower that's on the screen. So thinking back to that analogy of the vulva and vagina should be a little bit like the inside of our cheek because it's got a nice red appearance. That promotes and indicates good blood supply to the area. But going through perimenopause and menopause, what can happen is the drying out, inflammation and thinning of the tissues around that area can almost create a little bit of a more whitish appearance rather than kind of pink or reddish. And that's a sign of atrophic vaginitis or a vaginal atrophy. And what that does is it creates a little bit of rigidity in the tissues that makes it that the tissue doesn't kind of move over each other and slide, and it can cause irritation and discomfort down below. So that's one of the main symptoms. Another one of the symptoms is pain during sex. That can be with penetration, on insertion or deep penetration, because the tissues aren't able to stretch in the way that they're used to, and that can cause a lot of pain and a lot of sometimes even tearing and discomfort around that area, either deep or more superficial. It can be irritation with use of pads or on non-cotton-like knickers. And it's one of the most irritating signs that we tend to find in physio, and not the one that women tend to come and talk about. They'll tend to talk about something else, and then that will be an, oh yes, this is really, really irritating for me down below. So we see it quite commonly, but it's not often spoken about. And then common symptoms of pelvic floor muscle dysfunction. As you can see on screen, this is a diagram of you sort of standing to your side and crudely cut in half. The red-like structure, or the sausage-like structure, is the pelvic floor, and that's just to show you how it sits around the bladder, vagina, and the back passage. The common signs and symptoms of pelvic floor muscle dysfunction include pelvic organ prolapse, and that's normally characterised by a feeling of heaviness, dragging, dropping. Some women come in and talk about feeling like sitting on a tennis ball or sitting on a stone, so that kind of pain internally and something doesn't feel quite right down below, but I can't quite pinpoint where that is very typical of women around perimenopause. Stress urinary incontinence and urge urinary incontinence again can be a result of how the pelvic floor is behaving and functioning. And I tend to use the hose pipe and kinking the hose pipe as an analogy. So if you've got a good functioning pelvic floor, it's a little bit like stepping on a hose pipe that's running water. If you squeeze it tight enough, it kinks the hose pipe and stops it from flowing. And that's the aim of the pelvic floor, is when it doesn't quite work properly, hasn't got the strength or that function, the water keeps on flowing despite our best efforts to try and squeeze it. So that can result. And it can also cause some bowel symptoms as well. So some of the more common ones that we see is frequency to go to the toilet, urge to go to the toilet, can't hold on, have to find a toilet now. We also have a term called toilet mapping, whereby if you're walking out about, you'll only go to places where you know there's going to be a loo nearby because it feels safe, because you know that urgency might come on. Sometimes it can also present itself with difficulty actually opening your bowels and ease of motion. So you're on the toilet for a long time and you're straining, and it's quite hard to feel like you've had a complete void. And 1 in 3 of us will experience these symptoms at some point in our lifetime, which is quite a large proportion of women. But what a lot of us don't know is that 60% of us can make a significant difference to our quality of life and change our symptoms with really small tweaks to our lifestyle, which I'll come on to in a bit. So risk factors. So if we're thinking about preparing or thinking about, okay, I don't want to have any of these symptoms later on, am I at risk, what can I do to help? Thinking about risk factors of pelvic floor muscle dysfunction. Those who have chronic respiratory diseases, lots of coughs, or sometimes in pregnancy, if you're sick quite a lot in the first trimester, that can put a lot of strain and pressure going through your tummy that goes directly through your pelvic floor. Because it's at the very bottom of us, gravity unfortunately doesn't favour it, so it all goes downwards, and it means it has to work really hard. So that overstretch and overpressure can put a little bit of demand on quite small muscles. If you're in a role or a job where you have to lift, push, pull, move things quite a lot, that can also increase tummy pressure that causes a bit of bearing down and lack of support down below. Constipation. This is probably the most common one that I see clinically, is those who find that they have quite slow moving bowels, or everything feels quite hard, or it's quite hard to pass and it feels quite constipated. That pressure and repetitive straining just to get off the toilet because you've got a million other things to do, and rushing on the toilet puts a lot of pressure repetitively on your pelvic floor, and it's something that happens for most of us every day. Weight management, from a physics point of view, if there's more weight going through your pelvic floor, you've got to have more of a force of muscle contraction to oppose it. So that's also a risk factor. Some that aren't on the screen that I think are important to mention are obstetric history. So thinking about pregnancy and childbirth. Thinking back to that very first slide of the cycle of estrogen, those of us who go through vaginal delivery but had a little bit of a difficult time, so had a tear to the perineum or had instrumental support with the delivery, had a particularly well-cooked baby that was quite hard to get out, it can have a big effect on the pelvic floor that can make an excellent recovery at the time, but sometimes kind of rears its head again around the perimenopause and menopause time. So if there's no other reason, sometimes we can trace it back clinically to that kind of history, and it just puts someone at slightly greater risk. And anyone who's had a previous history of kind of radiotherapy around the pelvis area can sometimes make those vulval and vaginal tissues a bit more irritated as well. So how can I look after my pelvic floor going through menopause, perimenopause, menopause, and also and beyond? In no particular order, fluids. I very commonly see men and women who come into clinic and say, well, because I leak, I just try and drink less, then I'll leak less. But the problem is if you're drinking less, your urine's more concentrated, and actually it irritates your bladder and you want to wee more. So drinking 1.5 litres to 2 litres a day is definitely recommended, and try and avoid the irritating drinks like the citrusy drinks or alcohol or fizzy drinks or sugary drinks. They all irritate the inner lining of the bladder and actually make that urge to go much worse. And if the stronger that urge is, the harder it is to fight. Weight management. So again, reducing how much pressure is going through that pelvic floor, the more chance you'll have of a bigger, stronger and easier contraction. Smoking cessation, thinking about blood flow to the area. Reducing or stopping smoking can help improve circulation. Diet, and I talk about diet more from a bowel health point of view rather than influence on hormones. But alongside fluid management, if we can introduce a little bit more fibre into our diet, what fibre does, particularly insoluble fibre that's found in chia seeds, flax seeds, psyllium husk, oats or all bran, it helps absorb water into your poo, and it makes it easier for your gut to actually pass through and then easier for you to expel afterwards. So you actually don't have to strain at all. You have quicker motions and can get off the toilet faster. So and in the West, a lot of us don't actually meet the recommended fibre amount. So we really want to just make a bit of effort to introduce a bit more fibre into our diets. Exercise. Now this is twofold. Although there aren't any guidelines available at the moment of how women should exercise in the menopause, although there is some exciting research at Bournemouth University with Kate Rathley looking at how exercise physiology can be influenced in the menopause, there is some evidence to suggest that doing some weight training is going to be really important. So if you do a little bit of weight training every week, it will help promote muscle mass and also promote bone health. The problem that I also find in clinical practice is that I've got women who are really motivated to pick up some weights and do something, but unfortunately it makes their symptoms down below a bit worse. So they a bit of a rock and a hard place, they're not sure what to do. So my recommendation is always, all activity counts. So do something that you enjoy and feels good for your body. And the kind of weight-bearing exercises that can be in Pilates, weight-bearing through your hands can really help. Also resistance exercises like swimming is a really nice way of just really exercising those muscles and is really good for your health. The second is pelvic floor muscle training. So when we're thinking about pelvic floor muscle training, the way I tend to teach pelvic floor is it's a 3-part movement in one. So the first way I teach it is I would get someone to imagine that they're holding in wind in a really busy lift, and then imagine that you're squeezing around the front passage as if you're trying to smuggle diamonds into an airport or close the opening, whatever makes you think of the right bit. And then you lift up and inside you before letting go. Some people also describe it as a zip that starts around the bottom and it comes around the front and lifts up and in before unzipping and letting go. Now I can see a few people are doing it because there are a few eyebrows going up and a few shoulders going up, which is great. And it's about finding the right bit and getting to know your pelvic floor as early as you can, because it is your friend now and through towards later life. It's with you and you can use it. The guidelines recommend that we all should be doing pelvic floor muscle training 3 times a day, practicing squeezing and dropping and also squeezing and holding for 10 seconds. And both those exercises are really important because one will help you get to the loo in time and the other will help save you when you need to have a quick cough or a quick sneeze because it braces down below. But when I talk to women about doing their pelvic floor, even by physio standards, 3 times a day is a really big ask and we're all busy enough. But I would encourage you to think about how you can embed pelvic floor muscle training in your day-to-day routines. So think about something that you do day-to-day that you already do more than once a day. That might be brushing your teeth or waiting for the kettle to boil or driving, and make that your cue to do it, because if you do it enough in that way, it becomes a habit and then it becomes second nature and it becomes really helpful later on in life. Probiotics. Any probiotic that contains lactobacillus that has an evidence base that it gets down into the vulvar or bladder area, there's some evidence to suggest that it might help to reduce against the frequency of urinary tract infections and also help with comfort down below. There's a little bit more research going on at the moment about vulval and vaginal biomes and how that kind of system itself can help with self-cleaning and self-management, so that's quite an interesting area. And also topical creams. The first is low-dose hormone replacement therapy, and that can come in the form of creams or tablets or pessaries. And for most women, they are safe to use under the supervision of a consultant or a GP. And when we're thinking about the dosage of estrogen in these sorts of creams, 1 HRT tablet compared to the use of creams, if you use the creams every day, it still wouldn't equate to the amount of estrogen in 1 HRT tablet. So it's very, very low dose. It introduces a little bit of synthetic estrogen into the area that can help plump up and support the tissues. The other is a form of vaginal moisturizers. So a lot of us ladies in the room would probably moisturize every other area of our body, but ignore the area that needs it the most. And there are some products down below that can help with lubrication and it can help with comfort down below that I'll talk about next. So on the right-hand side is some lists of some common types of topical estrogens that could be discussed with consultants or GPs. Comes in creams. Vagifem is a tablet that you insert, and Invagis and E-string are more pessaries that you insert in the vagina and release a little bit of estrogen. And then the popular vaginal moisturisers that are recommended by some of the gynecologists at UHD are the Yes Vaginal Moisturiser, the Hyalofem. And thinking about intimacy and sex, I'd always recommend using a water-based lubricant, and you can't overdo it. It's about using it before and during if you need to, and normally your partner won't even notice. It's just making sure that you feel comfortable, because if a little bit of elasticity is lost in those tissues, using lubrication is going to help those surfaces move more comfortably over each other. Now, I've covered a few of the strategies that we use in pelvic health physiotherapy, but I would encourage anyone who wants to know a little bit more to the UHD internet page. So if you go on the University Hospital Dorset page, click on our services, click on physiotherapy and pelvic health physio. My team have created some really, really good videos and really good handouts to give you some more information. But thank you for listening.
Hello. Can you hear me? Is this on? Everyone can hear me. Perfect. Hi, I'm Emma. I'm a senior lecturer here at Bournemouth University, and with another hat on, like Rosie, I've got a few. I'm a GP with a special interest in women's sexual and reproductive health. I work clinically still 1 day a week, and I'm here 4 days a week at the university, and I'm also doing a PhD in women's sexual health as well. So that is me. I'm just going to go through one slide. So I appreciate the next slide's quite busy, but I'm going to spend 20 minutes talking through it. So please don't try and read it all at once, and I will guide you through it. So what I'm going to talk about is the biopsychosocial approach to sex across the menopause transition. The reason I think this is really important is without considering a very holistic approach, we often miss the point and actually could be treating something that is not going to cause any help for anyone. I also want to fully acknowledge that as a GP, I see women who are often coming with challenges around the menopause with sex. People don't book appointments to say, my sex life is great. I wish they did, because that would be a great GP appointment, but they don't tend to do that. And therefore, I appreciate I'm coming from the negative slant. However, some women actually have a real sexual awakening during the menopause. And Peggy Kleinplatz, who's an amazing researcher, has done fascinating research on magnificent sex and what makes magnificent sex, and she's written a book with the same title, and she says that the best sex of our lives tends to start at the age of 55 is the mean age. So put that in context with all the negativity I might be talking about in the next 20 minutes. So what is biopsychosocial? So that is acknowledging our biology, our psychology, and our sociology. And whilst I'm going to focus about the menopause time and time of the perimenopause, things that have happened earlier in our life can really influence this stage. So I'm just going to go through things that if a woman comes to me and says, I'm having problems with sexual desire, or some part of my sex life is not working and I really want some help with it, they might come with an idea of what they want, and that is really important to then talk about why they feel like they want that and kind of say whether that is going to be appropriate management for them. However, I really want to make sure it's in context with all these other things and go through all these other things with them to make sure that if I do come up with any sort of medical management, it's actually more likely to be effective than if I try something that's actually really not going to be effective for them. So, starting off, poor sex ed. How many people in the room had great sex ed at school? For those online, no one's putting their hands up. So, our sex ed, I would say traditionally, and I think hopefully it's getting better, there is a new comprehensive sex education curriculum. However, I did search and the word pleasure is not in that comprehensive sex education curriculum. It's very limited, and it's really not pleasure-focused, and it's particularly not pleasure-focused from the female anatomy point of view. In sex ed, we often got taught about female anatomy, and it was all that, that ram's head view of female anatomy. It was the ovaries, the fallopian tubes, the uterus and the cervix and the vagina. Everything that is related to babies, but nothing that's related to sexual pleasure, really. I'm not sure how many of you got a full three-dimensional view of the clitoris in your sex education, whereas that is actually where most of females or people with clitorises get their sexual pleasure from. And therefore not teaching people about this leads to them going into sexual encounters which are really unsatisfactory because they don't know how they're meant to have pleasure. And this represents onto the next slide that different cultures, different traditions, different religions view sex as only for procreation, and that is sort of filtered down into some of our sex ed as well. And that has also influenced how society views sex. We have a very limited definition of what sex is, which can be summed up as the coital imperative in heterosexual relationships. So if a man and a woman are having sex, what do you think sex is? And I'm just going to let you think about that. But most people would say it's a penis going into a vagina, whereas actually sex is so much broader than that, and this can be really empowering across the menopause transition if penetration is painful, because if you think oral stimulation, manual stimulation, massage, having a bath together counts as sex, then you could have an absolutely great sex life with nothing needing to go into your vagina. And that is really powerful and really kind of empowering women. However, if you think about the language around sex, we've got the bases and what counts as a home run and a fourth base in America. But in English culture, we talk about foreplay. And that is really minimizing what actually most women find the most enjoyable sex act at a population level. Now, if you are one of the 4 to 10% of women who can orgasm through vaginal penetration alone, go you, do your thing, that's fine. But I'm just saying you're not abnormal if you don't orgasm through vaginal penetration alone. And this has led to what is called the orgasm gap. And the stats here are for males in heterosexual relationships orgasm 95% of the time in sexual acts. Women orgasm in heterosexual relationships 65% of the time. Now, women in same-sex relationships are in the 80s, which I think represents how, for them, they have gone out of this societally created view of sex and actually have got much more wider sexual repertoire, and they can do things more frequently that cause pleasure. So I think we just need to broaden our view of sex. Another thing that society views more historically as being very taboo was women having solo sex or self-pleasuring. Now, how are you expected to know how to direct a partner to what you want if you don't know what you want because you haven't found out? So if women are coming with me with sexual difficulties and I say, well, how do you like to, what historically has caused you pleasure, and they say, I don't know, well, how are you meant to communicate that with a partner? And how are you, so yes, learning how to, learning what you enjoy as a couple is really powerful, but if you've got that pressure of someone else in the room, and you don't know if you're going to have an orgasm, and then you don't really know what to do, you don't really know how, what you need to make you feel pleasure, having that other person can be a real pressure. So sometimes doing it by yourself, and actually working that out to then be able to bring that into a relationship can be really powerful. So that's just some of the background. That's more the social aspect, and we've got some more social stuff coming. But to mix it up, we'll go to systemic hormones, which is very much focused more on the menopause transition here. And like Rosie's lovely diagram, it's a little bit haywire for a bit. It's all up and down, up and down, up and down. And if you're having hot flushes because of that, if you're having disturbed sleep, if whatever your partner does is a little bit irritable, and if you have got hormonal-driven changes in your physical appearance, so your body fat distribution changes in the menopause, you go from that more pear-shaped female, traditionally, considered structure to a more apple shape, that can really affect your self-esteem and how sexy you feel. And actually all those things can really impact your sexual desire, your libido. And therefore, addressing that with either medication or lifestyle changes can really impact your feeling of sense of self and your ability to engage with sexual activity. Now, this is where the testosterone element does come in, and this is probably if a woman is coming to see me and has concerns about her sexual desire, talking about testosterone is probably one of the first things on her I'd like to chat about list in the patients that I see. Now, if we have in the guidance, it is those guidelines that if a woman is already taking systemic HRT and she is suffering with low libido postmenopausally, we can consider testosterone treatment. That is in the guidelines. There is no product available on the NHS that is designed for women, so no testosterone product that is designed for women. There is a product called Androfem, which is produced in Australia, and we ship it across, but that's only available privately. However, it is in guidelines that we can use the male product at a female dose, but there needs to be a discussion with the patient if you're in a sort of clinical setting that is you're using a male product. You're not using a product that was designed for what we're using it for. However, it is in the guidelines. You would need to have a blood test to check that actually your testosterone is low, because if we're giving a female testosterone and making her higher than the actual physiological range for a female, you're more likely to get side effects like deepening voice, male pattern hair growth, those sorts of things. So it is definitely something that's available, definitely something that you would need to have a clinician who's happy to start it, know the parameters, know how to monitor it, and actually if a GP has not had that training, then they might absolutely feel not able to do so and then refer you onto the menopause clinic. You might find GPs who do have special interests who have gone through that training, because it's not like just giving you, a tic-tac and letting you go. You need to monitor it and make sure it's the right thing for you. And the guidelines do say if it hasn't made a difference within 3 months, we tend to stop it, because there's not a clear correlation between testosterone level and libido. So everyone's individual, everyone's unique. Normally, if you're in the lower range of normal testosterone, there is no harm in giving it a go with the discussion about possible side effects and those sorts of things. But if it's not helping, we do stop it. Moving on now to more of the social things again. Sexual dynamic with your partner. It's often harder to talk to your partner about sex than have sex. So we really need to bring in, ideally from an early stage in relationships, because it is harder later on in life, but we can all start from somewhere, how to talk about sex openly, as if you're talking about the weather. What do you like? What do you not like? What's great? And there are some amazing books about this, because I do not have time to do this in this lecture. But there's some great books like Karen Gurney's Mind the Gap, Esther Perel's Mating in Captivity, the Gottmans do some great stuff, all about talking about sex and being able to do so. Karen Gurney also talks about this thing called sexual currency. If you're just in a place in your life where sex is not what you want, and that can be, say, like postpartum or something like that, having sexual currency can really help foster that intimacy within a relationship without having any pressure to engage in, further up what we would traditionally call the train of sex in terms of penetration. So that's the things you wouldn't do with your grandmother that sets apart your relationship with your partner compared to any other relationship. So that is the hand on the waist, the cheeky bum tap, the long kiss before you leave for work. Those sorts of things that really can drive intimacy, but with no pressure for them to go anywhere else. That is the sorts of things can really improve relationships and things that you can discuss with your partner saying, I'm just not feeling ready for this, but I really value the intimacy. I really want us to feel like we are a partnership in life and we've got that special connection. Can we do this? I really want to be able to kiss you lovingly without any pressure for it to lead anywhere further, because I just don't want to, therefore, it stops me giving you that kiss. It stops me having that playful, flirtations if I have that pressure for it to go somewhere else. Poor relationship satisfaction. This is one I always check. If you hate your partner, you're not going to want to have sex with them probably. So actually check that you are in a good place in your relationship, because as much testosterone as I give you, if you don't like your partner, you might get high libido, but libido to have sex with your partner, maybe not if you hate them. So there's some really good books out there and people who have talked about this. So the Gottmans and Esther Perel have two non-mutually exclusive schools of thought. So the Gottmans are all about having a best friend, and Esther Perel's more like distance creates eroticism. And there's a really good literature review out recently by Amy Muse, who wrote about how, Esther Perel talks about this again, how doing novel things together with your partner really gives you that sense of self-expansion and otherness. You can see your partner in a different light. It's like people find, say, if you have someone and you go and see them at work, it's a different way that you've seen that partner, and sometimes you can see how other people see them, and it makes you feel really attracted to them again. So those are the sorts of things that you can do to foster that relationship. Now, this is a very heteronormative section of the talk I very much appreciate, but there was a really interesting article that came out, I think last year, called The Heteronormativity Theory of Low Sexual Desire in Women Partnered with Men. And I'm just going to go through a couple of these because, again, I'm conscious of time pressure. But things that can really impact women's sexual desire that as much testosterone or hormones I give you is not going to change. Inequitable divisions of household labour. And I am not just talking about who physically does the tasks, like does the grocery list. I'm thinking of who has the mental chore of making the list, checking the mustard's not gone out, checking the loo roll hasn't finished, checking we've got enough floss in the cupboard, making the list as well as actually doing the groceries. If you've got a mental list of, I haven't done the washing, I haven't done the groceries, oh my God, we picked up the person from school that we were meant to have, we left them. If you're engaging in sex and you've got all this running through your head, you're not able to be mindful in the moment. And Dr. Laurie Brotto has done some amazing work. She's got a book called Better Sex Through Mindfulness. And it's about how actually being mindful and in the moment in a sexual activity is transformative. And if one of the partners has got this mental to-do list and the other person doesn't, that's going to cause a discrepancy in sexual desire and sexual satisfaction. It can also lead to resentment if one person's covering an unfair burden and workload of the household chores, which again impacts sexual desire. The other thing that I'm going to talk about, and there is the list there, but blurring of the partner and mothering roles. There is nothing asexual about being a mother, but you do not have sex with those you're mothering. And therefore, if your partner takes on that sort of, if you're mothering your partner by, always doing their laundry, making their bed, cooking for them all the time, if you're doing the mothering roles for them, that really can psychologically be, even subconsciously challenge that sexual desire because you're doing the roles of a mother rather than a partner. The other thing to do is just, again, in education, is understanding sex drive. Now, Emily Nagoski has written an amazing book called Come As You Are, and she's actually written one that was released last month called Come Together for More Long-Term Sexual Relationships. But she talks about spontaneous versus responsive desire. Disney ruined us. We're all meant to want sex, all the time, with no apparent trigger, just because we want to if we're in love with someone. And that's apparently, unfortunately, not actually how it works. After 6 to 18 months, we go from, particularly women, go from spontaneous to responsive desire. Men can keep spontaneous desire for longer than women. However, responsive desire is by far the most prominent sort of desire in relationships and long-term relationships. So this is that feeling of, I didn't want sex, but every time we have it, I think, why don't we do that more? And that feeling is responsive desire. And I really need to emphasize that this isn't a excuse to be coercive. It is about engaging and having that communication. So this brings back into the sexual communication of, I really want to lie with you. I really want to see how I feel after having a massage. I really want to engage with some kissing, lie with you naked, and see what happens with absolutely no pressure. Because what responsive desire, is that desire comes after arousal, rather than desire leading to arousal. So you have got some of that physiological arousal, and that makes you, I'm horny. Let's go for it. But you need both partners in any sense. If you're trying to kickstart your responsive desire, both partners need to be able to disengage from the sexual activity with no repercussions, either physical or emotional, and have that ability to say, thanks, that's great, I'm just not feeling it, but I love what we did. There's also the dual control model of sexual desire, which is about understanding both what turns us on, but actually learning what turns us off. And that's like that shopping list, or the fact that the door's not locked and the cat can walk in. Anything that turns your off switch, so it turns your on switch off, is just as important to address as what turns your on switch on. Finally, I'm going to talk briefly about genital urinary syndrome and menopause, which Rosie talked a lot about, and she's covered a lot of the groundwork. So I feel that I can just brief over this a bit, but it's normal to not want something that hurts, and actually genital urinary syndrome and menopause can make any sexual contact painful for women. So therefore, lube. Just use lube. Any age, use lube. It makes it so much better. So you've got water-based lubes, which are your good all-rounders, but they can be quite tacky, and they need to be reapplied frequently, so that can interrupt sexual activity. But they're a great all-rounder. You have oil-based lubes, which can be more long-lasting, a bit more soothing, but please don't use them if you're using condoms for either pregnancy prevention or STI prevention, because the oil in the lube will break down the latex in the condoms. And then there's silicone-based lubes, which actually ladies going through the menopause can find really helpful. It's particularly long-lasting. But if you are using sex toys, please read the label. They probably say if they're good quality silicone sex toys, not to use silicone lube with them, because it can degrade the silicone in the sex toy, which makes it more porous and therefore can hold bacteria and viruses more, and which is particularly important if you're sharing sex toys without sterilising them, which you shouldn't do anyway, but if you do, just be careful with using silicone lube. And also it can degrade the silicone in sex toys, potentially make them just disintegrate, and if you spent a lot of money on a good quality silicone sex toy, you do not want that. So final thing is talking about the estrogen. Like Rosie says, you can have it as pessaries, which are often tablets which go into the vagina, but you can have it as creams, which you can use internally and externally. They are very good if you have involution of your vagina, vulval structures, which can happen. If you think about the clitoris and the labia minora, so that's the clitoris and the inner lips, they look very different pre-pubertal to post-pubertal. That's because they're estrogen receptive tissues, and they can resolve post-menopause without that estrogen. So if you get vaginal estrogen on those tissues, that can help you with sexual pleasure, because it's those tissues that become very engorged and sensitive during sexual arousal. So by using the low-dose vaginal creams on your clitoris or your labia minora, that can help with sexual pleasure and sensitivity. Using sex toys can also help, because you will reduce blood flow and reduce innervation of those structures as you get older, can make it that it's harder to have an orgasm than it was before, and therefore using sex toys can give much more stimulation than any penis, tongue or hand could ever do. And glyceral stimulation, the air pulsing ones, are particularly useful for that condition of not being able to have orgasms as easy as you used to be. Recurrent UTIs are due to that microbiome change, so lactobacilli is one of the most prominent healthy bugs in the vagina in the premenopausal stage, and in the postmenopausal stage or in the menopause transition, when the estrogen drops, the vaginal pH drops. makes it not nice as healthy. The lactobacillus doesn't like that environment so much, which makes things like Candida, which causes thrush, or E. coli, which cause UTIs, more able to take over. So that's why having the vaginal estrogen can be a really good treatment for those either recurrent UTIs postmenopausally, or like Rosie was saying, that like irritation symptoms. And then, like Rosie was saying, the vaginal moisturisers as well. So, unfortunately, I can't do that in a 10-minute consultation, but that's a very brief overview of some of the things to consider if you are having any sexual challenge across the menopause transition, or actually earlier, because I appreciate not all of them were life stage specific. But yeah, I will stop there and ask for any questions. I'm sure we'll answer them.
Yep.
Oh, right, there we go. Yeah, well, if you hold it and then you can kind of go, depending on what the question is.
No problem.
Okay,
that's all
so
right.
we've got about 4 here from
Perfect.
people online. The first one is, I'm suffering with anxiety at the moment. My GP keeps telling me this is because I'm going through the menopause. Is this true, or are there separate issues?
So, disclaimer, I cannot give any personal medical advice in this educational setting because I am not your, well, I don't know, but I'm probably not your personal GP, and this is not an individual one-to-one consultation, and I don't have access to that person's medical record. What I would say is, if you don't feel like the diagnosis is correct, or you would want to revisit a possible diagnosis, you can always go back to ask either the same GP or ask for another GP to rediscuss your symptoms and see what they... whether you feel like you've not been taken seriously, or whether you just are questioning why that diagnosis has been given. Always can go back and have another chat to another or the same physician and just ask why they thought it was that, or if there's any reason why you're thinking it's something different. All I can say is you can get mood-related symptoms in the menopause, so that might be why they thought about it, but everybody is unique and there's often lots of different causes for mental health issues, so yeah.
Okay, so another question is medication the only way to relieve my menopause symptoms? I'm worried I'll never come off medication.
No, actually. So actually I've got a diploma in lifestyle medicine as well. So actually there are lots of different lifestyle things that you can do to support menopause. And again, every individual is unique. The root cause of menopausal symptoms is hormonal, and therefore giving hormones can help, but there's so much other things we can do. So lifestyle is an amazing one, like Rosie was saying. You've got diet, you've got exercise. Some people do find supplements can help. All I would say is with supplements, they are an unregulated profession, so what they say is in the bottle, unregulated profession, unregulated industry, so what they say is in the bottle is not always in the bottle, so do be careful of that. Menopause Matters has a great alternative therapy section, so I would say probably go and have a look at that, because I don't have time to go into everything today. Some people do find alternative therapies like acupuncture can be really helpful. There's a really interesting research going on here, I think Cam's doing it, with cold water swimming, and that also gives you a real good social activity as well. So I think it depends specifically what menopausal symptoms this individual's having, or anyone's having, because everyone does have unique symptoms in the change. But yes, lifestyle can be really effective, is all I can say. But again, depending on the specific symptoms relating to different lifestyle events. But exercise, nutrition, social support, and some supplements and other alternative therapies can be helpful. I don't know if Rosie wants to say. No, Rosie's happy not to say anything else.
Okay, so the next one is, I'm scared to ask my boss, who is a male, for support with my hot flushes. I'm sat in a room with young people who are always cold, and I don't feel like I can ask for support from my boss with this.
Oh, bless. I think it's really difficult if you don't feel you've got the support to raise it. I would say, is there anyone in the office at all, or a friend, or anyone in work or out of work that you can talk to? Maybe HR might have another person that you can talk to. I don't know if they're from BU or not, but if they are from BU, there's a workforce policy that they can read and present to their to their boss. If they're not from BU, maybe is there a menopause workforce policy that they can find and, read up on and present and give them that confidence that they have their backing. But I think it is a really hard one if they don't feel like they have the support. But see if there is a policy, maybe talk to HR, see if there's anyone else who, even if it's not in their department, who might have had similar experiences, or is a boss in another department who might seem a bit more supportive. Yes, I think. But unfortunately, I have medical experience, not business experience. But that's what I probably get.
Yeah, no, thank you. And it sounds really tricky. It's quite frightening when you have to sort of advocate for yourself in those sorts of settings. There's a new sort of paper that just come out in the Lancet this week that was talking about how work's being done to try and get menopause on the Equality and Diversity Act, much like pregnancy and perinatal already is. So a lot of work's being done in the background to educate and support managers to support their staff, because this is a changeable point in life and they want to support you and retain you in work. So as hard as it may be, it's about having those conversations in whatever way you feel you can.
I think there's obviously talks about this, but I think there's the balance between putting it as a disability, to have it within that framework. We don't necessarily want to categorise menopause as a disability to get it in the legislation. So I think it's a very challenging point,
Okay, another one is, how many reps should be done when doing pelvic floor
That's a great
exercises?
question. And on reflection, I really should have said that in my presentation. So thank you for whoever asked that. The general rule is 10-10-3. I think that's the easiest way to think about it. So the 3 is 3 times a day. The first 10 is 10 squeeze and drop. So that's a sort of faster, quicker oomph contraction and release. It's as important to let go as it is to squeeze. And then 10 repetitions of 10-second holds. That's the hardest one we tend to find people do, being able to sort of lie or sit or stand and really retain that contraction for 10 seconds. So 10-10-3.
Okay. And the last one from online, can mindfulness help with the menopause?
Yes. It really can. I think it depends, again, what particular symptom of menopause you're referring to. But again, I think the short answer is yes, and it's really good for all other aspects of life as well. So it's a win-win if you integrate that into your life. There's some great apps out there.
Is there anyone in the room who has... one sec.
We're just going to bring the mic so that online audience can hear the question as well.
Sorry to put you on the spot.
I was just wondering, running or jogging, taking up the couch to 5K, which kind of I've been encouraged to do, but then a lot of people of my age say, you must never run, you only walk. Is it bad, or does it kind of help your pelvic floor in a way?
Great question, thank you for asking. Running is a great form of cardiovascular exercise. To break running down, it's effectively hopping on one leg repetitively for a prolonged period of time. So there's a lot of control and strength that's required to run in a way that feels good and is supportive for your body. And we find that a lot of ladies like to run at different points in their life because it's free, you do it at your convenience, and you get outdoors and it feels great. In relation to the pelvic floor, it's one of the hardest exercises to try and return to. And the reason being is you have to have really good coordination and functional strength of your pelvic floor to support you from the bottom up. I would recommend that running is always worth trying and find an exercise that works right for you. But if you start to find that during that running experience you start to feel, I feel quite tired, or everything feels a bit achy, or you start to feel dropping or any sort of leakage down below, that's okay. Come back a little bit and perhaps run a little bit less where your symptoms aren't present or nothing's stopping you, and then you can progress from there. So one of the biggest parts of my job is people who are a little bit overactive and are exercising past the point that their pelvic floor can function. That's okay, come back a little bit. When does things stop? Can we then progress forward? So it's safe for you to do and it's healthy. It's just based on the individual.
A couple of questions. The first one is this being recorded so those out here can revisit the video? Because I know my memory, I I won't be able to retain all the good tips and all the things that you explained, including the 10-3-3 or 3-10-10 rather. And I already forgotten the second one. It's going to come back to me.
Yeah, to come back.
Yeah.
Thank you.
Any others? There's one down here. Oh, and there's one, 2 rows in front and 4 rows in front of you.
Hi, thanks so much for the great talks. Just a question about preventative. Obviously, you have your own fields, and I don't know what symptoms I may end up with, but are there any things in your fields that you think are really particular as a preventative measure to stop some of these more severe symptoms?
Yeah, you start.
Thank you. That's a really good question. And I think, again, coming back to that recent Lancet publication, I think it's really important to positively frame this transition. Everyone goes through it individually, and it's about empowering people who experience symptoms that were previously silenced to talk up. But that's not to say that people will get them. It's just if they do happen, we want to empower you to access health, know where to find support, and talk amongst your friends, because that's the most important thing. In terms of, from a physiotherapy point of view, I see everything at the very end of you. So the most common symptoms that I see tends to be stress urinary incontinence, and that can come at different points in life, and menopause is just one. For example, during the COVID pandemic, our referral rate went up 3-fold because everyone had that long chronic cough. So that's one of the kind of most common ones we see. And a lot of people, 50% of women over the age of 50, have pelvic organ prolapse. But a lot of people don't even know they've got it because it's not symptomatic, it's not affecting them at all. So it's nothing to worry about. But we tend to find the biggest driver of that can be bowel habit, constipation, and managing that as best you can is one of the quick wins that you can do that your future self will thank you for.
Yes, I agree. I think we don't want to demonise the change and make it that you are going to get all these different symptoms, because actually some women have absolutely no symptoms at all. Some women might have a bit of vaginal dryness, but actually systemically there's no hot flushes. So I think it really is unique. But I think just leaving as healthy a lifestyle as you can will really, support your health throughout any stage of life. I think, like doing your pelvic floor exercises, however young you are, is great, even if it's just getting to know that part of your body, so then you can engage with, but if you actually do them, that's great, but just getting to know what your pelvic floor is. And then, healthy diet, healthy lifestyle, being physically active, these are all things that, going back to that lifestyle question, can really help with symptoms. So if you're integrating that, it might be that you might have if you were to have symptoms, they're milder than they were.
Hi, thank you for your talk. I really enjoyed. My question might be a little bit broader rather than like the physiotherapeutic point of view, but my question is, menopause is not something about just sexual.
No.
Of course it involves, but it's not only about sexual or reproductive thing. That we can talk about, but we have a lot of different physical, psych, or cognitive problems, just as you said in the talk, like pelvic floor problems and bladder problems and stuff like that. But there might be some people who disagree with this, but still talking about menopause is kind of being tabooed to talk about to other people, and even with our family members or close peers. Even with their daughters sometimes. Can you share me with your thoughts about why this kind of thing might happen, and still it's much more open to talk about nowadays, but still it's not really universal to talk about openly about this. So can you share me any thoughts about this stuff?
Yeah, so I think in terms of menopause being a taboo, I think there has been, particularly in the last 3, 4, 5 years, a real drive to trying to make it less taboo, and real celebrity endorsement to try and talk about it more depending on what your social media feed is created it can be everywhere. And there's been documentaries on it to try and make it much more publicly aware. And I know the Women's Health Strategy, which is trying to support women's health in a 10-year plan that was released in 2022, had menopause as a real key stage, and that was talking about lifestyle changes and really trying to make women's health in general less taboo. And absolutely, menopause can affect the whole body. We have estrogen receptors everywhere, which makes why it can be so challenging to diagnose or rule out other things. So, you know, you can get tinnitus, which is ringing in your ears because you've got estrogen receptors in your ears. You can get hot flushes, mood changes, all these things we were talking about. I think with regards to making it less taboo, I think if we just need to talk about women's health in general and talk about life stages in general more to be these things that we used to not talk about because it was just quote unquote women's problems and something to put up with. I think we really need to just change that whole dynamic regardless of what stage of life it was at. Yeah.
That's a really interesting question, thank you. And thinking about that stigmatisation and taboo, they reinforce each other. And one of the great things about medicine is that everyone's eager to learn and learn more. And maybe going back a few more years, there was a little bit less understanding about how women could be supported. And some people in the healthcare system were unable to offer the support that may be available now in response to some of the symptoms that are coming through. So women who previously felt, and maybe still do feel a bit dismissed, it's about knowing who to talk to. Coming back to that first question, there are particular GPs like Emma who specialise in women's health and have a different skill set. So keep having those conversations. But it's still a little bit of advocacy that has to come from yourself as much as we are there and promoting it. It's important with the interest in the room, talking amongst peers and normalising, hopefully will change the narrative around it.
Yeah, and going back to that, I think one thing that's often said and could be potentially relevant to one of the first questions about whether they think symptoms are due to menopause. If you've got a GP and you want to talk about it, not every practice, but a lot of practices do have someone who has a special interest in women's health or menopause. So you can always ask, if there is someone there, can I speak to that person? And often they will have done additional training or just reading around the topic in their own time at their own cost. So we can't expect at the moment to have every practice to have it because it's often self-driven by that individual who's going above and beyond to learn it because they want to help. But if they do have someone there who has that skill set or even just that mindset, try and speak to them. Oh, are we able to ask more questions? One more, okay. Yeah. Yes. Yeah, okay. Okay, yes. So, not something I ever got taught in med school, proviso, just a statement of thing. And we don't get taught about supplements per se because they're not pharmaceuticals. They're not, and I think he's changed quite a lot. But about 2 years ago, a professor in neuro-ophthalmology from Stanford University called Andrew Huberman started a podcast, and he talked quite a lot about sleep in the beginning stages. So I would say maybe see if you could read some of those, but listen to some of those podcasts because they are quite in-depth. But yes, there is an association with magnesium and sleep onset as far as I'm away from the literature. It's not something I've looked up in the last few years, so it might be something that new research has come up that I'm not so familiar with, but there is some evidence about magnesium supplementation and supporting sleep onset. Andrew Huberman, doctor from a academic point of view, not a medical point. Andrew Huberman, Huberman. He does a podcast called the Huberman Lab podcast. He talked about it a lot in the beginning. I haven't followed his podcast for a few years, so I don't know which direction he's gone into. But those initial ones, he talked because there's quite a lot of different magnesium supplements. So glycinate, I'm showing I don't know enough about it to really give advice. But I would say go and look at people who you feel have the knowledge in that area and make a decision based upon what you're comfortable with. But I don't think many doctors would give advice about supplementation. Yeah. That's all right. I think we're going to have to stop there. But I'm getting looks, and nice looks, but looks to wrap up. So thank you everyone for coming. I think, is Lois wrapping up or are you wrapping up? Or am I wrapping up? I can wrap up. Thank you very much everyone for coming.